subset. Now what we can do, we started ARNI when the patient was having ejection fraction of around 30-35%, maybe even lower. Now he's having ejection fraction 40-45%, even up to 50%. Now should we discontinue these drugs? So no. A drug which has given you the benefit, maybe it is the beta blocker, or it is ARNI, or it is mineralocorticoid receptor. The guidelines are pretty clear that once you have been a heart failure with reduced EF, with not a cause which was reversible, but if you have chronic heart failure state which has improved with the use of drugs, you should always keep using drugs to enjoy a good longevity and life with good quality of life. So these are the recommendation, class 1 indication, that in patients with heart failure with improved EF after treatment, the guideline directed medical treatment should be continued to prevent relapse of heart failure and left ventricular dysfunction, even in patients who may become asymptomatic also. So these are some of the pearls. If we call ARNI as a molecule of the century, it will definitely not be an overstatement. It is definitely one of the very, very beautiful drugs in our clinical practice, which gives a lot of satisfaction to the doctor who is using it, lot of improvement in clinical symptoms to the patients also. And it is indispensable, definitely, and superior to ACE inhibitors we have seen by the RCTs in reducing cardiovascular death, heart failure death, and sudden cardiac death, heart failure hospitalizations in patients with heart failure with reduced. It also improves LV ejection fraction, which is a very hard indicator of mortality benefit of improvement. And it also reverses the adverse LV remodeling and improves the quality of life in these patients. ARNI should be initiated as early as possible. We know by the pioneer heart failure and transition trials that we can initiate it as early as even pre-discharge. And acute decompensated heart failure and de novo heart failures, ARNI should be given for at least 3 to 6 months along with other foundational therapies, and then the patient should be reassessed. This is one of the points we discussed, and should be considered whether the patient needs an ICT or CRT. ARNI should be used in all patients with heart failure with preserved EF, HFrEF patients also, and with EF up to 57 to 60, along with an SGLT2 inhibitor to reduce heart failure hospitalization and to improve quality of life. So thank you very much for patient listening.